private providers and make sure that the TB service reach people and linkage with the treatment. In Pakistan, Mercy Corps is the principal recipient for the private sector, implementing TB activities throughout the country and contributing to over 45% notification to the national notification, and with excellent treatment success rate as well, which has been maintained for 4 years. And this is an excellent example where the private sector contribution is really critical for ending TB. In Vietnam, the so-called PPM5, where intermediaries were engaged to bridge the public and private and contribute to improving access in TB screening, the double X approach, that's X-rays and gene expert testing, and linkage to treatment. This already contributed to TB notification. That's all GC7 and before. Now we are moving to GC8. You all know that we had the replenishment, and the Global Fund board already decided on allocation, how much each country will receive. And this allocation letter will be communicated this month, probably end of next week or so. And countries will be informed how much money will be available for them for the next 3 years. At the same time, also highlighting the strategic shift and adaptation. This is already in our website, or communicated as part of the outcome of the board decision. One is further prioritization of global fund allocation to the lowest countries with the lowest income and the highest burden of the disease. And the second shift is on defined predictable transition timelines for countries tailored on the context and disease burden and economy. The last one is very important for our discussion is on optimized use of available resource, including not only global fund resource, overall available resource with rigorous programmatic prioritization, co-financing, market shaping, integration of the service, including the private sector activities and communities system financing. As part of the overall Global Fund investment, you may also remember the reprioritization document which we shared with all the countries last year in June, and the need to prioritize the Global Fund investment, and also highlighting the low priority areas which could be deprioritized depending on the context, and the opportunities for optimization, efficiency, and other considerations as well. These are some of the examples along the cascade of care, but it's for the first time we are talking about areas which may not be priorities for global fund investment, including like using sputum microscopy for TB diagnosis. Well, we have now the NPOC and other molecular tests which could be used, better sensitivity and reasonable cost, and the mass test campaigns which may not yield a lot, so that there are options for more targeting. There are considerations also presented on this, and another example on highlighting the interventions along the cascade of care. You can see that for TB screening and diagnosis, the digital checks X-ray with AI molecular diagnostic test, the NPOC, the near point of care, now WHO already recommended. We had already included in our guidance last year, and we are happy that the WHO already recommended the use of the new near point of care, including tongue swab and sample pooling, also opportunities for efficiency and optimization, overall integration of TB service into primary healthcare coverage, and there are some low priority areas also highlighted. For treatment, a shorter regimen treatments are available and should be used rather than longer regimen, including for DRTB and TPT, and for prevention, prioritizing contacts and people living with HIV. And then on real-time and digital-based data information, all these intervention, not only for public, for private sector as well, including engagement of the communities. There are cross-cutting areas, including a key and vulnerable population, which requires more attention going forward. Just quickly, this is a timeline for the next cycle, the GC8. And as I mentioned, the allocation letter will be sent this month. And the first funding request will be, the window will be in June, the second one in July 27, and the third one on October 5th. This year, it's implementation year for GC7, as you all know. The implementation of GC8 will start in January next year. Most countries by then will have completed the funding request, grant making process, and focus on implementation. Just a few points to highlight here that TB, we have always been operating with low funding, with huge funding gaps. This was further reduced last year, as you all know, since last year. And there is urgent need to intensify advocacy for more resources, especially from domestic funding, but also through innovative financing, including health insurance and social protection schemes. While we continue advocating, the available resource and tools also should be used optimally and prioritized based on evidence, and accelerating transitioning to the new tools, including NPOC and the others, and treatment regimens, BPAL and others, and the approach, including dispute and pooling, and promote private sector engagement, market shaping, and community engagement, as well as these are already yielding a lot and should be maintained. And good country examples, including a private sector, which I have highlighted, should be adopted and scaled up. Integration of TB service within TB and with other health programs critical is including private sector engagement would be critical to accelerate ending TB. Finally, the Global Fund investment process, including the GC8 strategic shifts, would be good opportunities to intensify engagement of private sector, catalyze overall TB response, and accelerate ending TB. Thank you very much. Over to you, Petra.
Thank you, Mohammed. This is an excellent overview of where we are with the Global Fund funding, and appreciate you within the financial constraints really highlighting where some of the prioritizations and efficiencies can be made. And I've put in the chat also the link to the new point of care test that came out by WHO. And I think that's definitely one of the areas, as you highlighted, that's really important for private sector engagement and potentially change of PPM models. And so from that point, I'm really happy that we have an excellent panel who can shed light on all of these issues. And I would like to start so if the audience has any questions, please put them in the chat or raise your hand. We would love to hear from you, but I'll kick it off. So I would love to ask a question specifically to Arnab and to Obioma. So how can countries that are going to be preparing funding requests for the GC8, how can they strategically now think about these new point of care diagnostics that will be an opportunity to engage pharmacies or to engage frontline providers? So to do not just procure diagnostics in a regular way, but also shape the private diagnostic market. In what way can that improve affordability or better access to people? And what do countries need to do in this stage also to think about readiness for these new TB technologies? And if I can ask Arnab that question first and then go to Obioma. Arnab, go ahead. What would you...
Thanks, Petra, for this. Maybe let's unpack what the new point of cares actually allow countries, and what does it allow countries to kind of actually do. These platforms, as you all would read, as many of you are aware, are very easy to use. They're low cost. It actually allows you to decentralize TB testing. Now, in the context of private sector, let me talk about two potential models. One is, wherever the PPM models already being implemented, that is, there are private sector patients who are being catered or who are getting access to free diagnostics, either by linking those patients to public sector labs, or some hub and spoke models where they're linked to private labs, but the tests are being paid for by NTPs. In this scenario, I think there's again a large opportunity to kind of decentralize testing, because typically right now diagnostics testing is at the district level at larger facilities, and usually there's some kind of sample referral model which is established between spokes to this hub. It leads to a lot of challenges at this point of time. There are usually high turnaround times. Many times, there are capacity issue on expert and other platforms, and generally there are a lot of delays in terms of actually diagnosing patients. With NPOCs, I think there's an opportunity to place these new platforms, NPOCs, at private labs, private clinics, pharmacies as well. The cost of these platforms is very low. It's like less than $500. A lot of these platforms have multiplexing capacity. So I think there's also an economic value for private facilities to invest in it. You can imagine a model where the private facility is investing in a platform. The TB tests can be, paid for by the NTP or a donor or something like that, but the private facility can make money on doing like respiratory panels, HPV testing, or something else. So it need not. I don't think we should think of these as just sell it from a TB perspective, but I think for these facilities, really kind of sell the multiplexing aspect of it and how they can get value for their clients, for whoever seeking care in that catchment area. So I think there's a good example. Maisha Meds, as many of you know, is currently the process of piloting these NPOCs in few private pharmacies that are within their network in Nigeria. I think the model, how they're envisioning this will work, is that anyone who comes, visits these pharmacies, has TB symptoms or is considered as high risk, is offered on-the-spot TB test. Since the platform or the NPOC will be at the pharmacy itself, you can do a quick test, get a result in 30 to 45 minutes. And if it's suggestive of TB, link them to a health facility for further kind of diagnosis and treatment initiation. The second model is, where there are no PPM models, but there are a lot of private sector patients who are paying out of pocket for TB diagnosis and treatment. In India, we've been implementing the IPAC model over the last many years, where I think prices for TB diagnostics has been capped for patients seeking care in the private sector. Again, IPAC model, while it has been successful, has currently been restricted, or it's mostly larger labs, larger facilities who've invested in them, because the cost of an expert or a TrueNat platform is over $10,000, and because of that, like a lot of smaller labs, smaller facilities don't want to invest in it. We've also done a lot of work where we've seen that there are a lot of high markups for private labs, which increases the cost at which they can access a lot of these new technologies and platforms. So we can envision a situation where IPAC kind of model also is expanded to include NPOCs. And again, the idea out there is that through such a model, you target smaller towns, smaller tier cities, smaller facilities, which currently do not have a direct access to TB diagnostics or any molecular diagnostic platform. In India, again, I think we are currently exploring the possibility of including NPOCs and as well as open PCR platforms within the IPAC network. And the idea would be to actually use that to kind of saturate coverage in the private sector rather than really target large facilities and large clinics. Let me pause here, and maybe Obioma wants to come in and speak a bit more as well. Thanks.
Thank you so much. I think I'm very excited for today's conversation, especially for the new near point of care. I just want to announce that for 2025, Nigeria reached the so much awaited 85% treatment coverage, and we crossed it. We are about 87% treatment coverage. And to mention that 34% of that came from the private facilities or private sector. Our target is 35%. We are 34%. Mohammed was showing 2022-23 when we're just coming up. We had 23%, 29%, but here we are 34%, almost 35%, which is our target. And looking into that, a lot of that number from the private sector, more than 50%, in fact, 56 and above, sometimes 60%, are from the informal sector, which is located within the community. It means that these are very critical persons when it has to do with TB, and if you must progress as a country, especially high-burden country. So for us, knowing that the Global Fund funding is just mostly gap filling, it means that we should be thinking, especially with what's happening in the funding landscape in this GC8, we should think seriously using it just for that gap filling, strengthening the system and ensuring that we shape the market, which will help us lead into sustainability. And there are some things we're doing now because a lot of procurements are going on for this near point of care, and we are targeting the PHCs. In fact, we are moving closer to the community. He just mentioned measurable and some of what we want to do with community pharmacies, but this is where we want to concentrate. And most especially because it's rugged, it's more like needs less infrastructure, capacity, needs less capacity, it's cheaper. It gives us opportunity to ensure that diagnostic network and diagnostic capacity is built. So some of the things we are doing it in line for GC8 is, first of all, we're mapping our private diagnostic market. We're looking into all these standalone labs, private standalone labs, which of them are high burden, which of them have one type of molecular test or the other, which can leverage on. Can we bring them into board where we provide resources or commodities for them and find a way to incentivize or enable? Do we have can we just even look at those who have high burden in terms of presumptive that approaches them and see a way of placing some of these machines that are coming? So what we are looking at presently is how do we get closer to the to the community? How do we ensure that we map to know the capacity gap? Of course, if we're able to build a lot more capacity within that community area, it will also help us to boost, because whatever we are seeing now, where we say more than 50% is coming from within the informal sector, it means that there's a lot more that would happen if we're able to place these machines closer to them. And with that, we'll be able to concentrate the market. In concentrating the market, it gives us opportunity to have the audacity to even come on the table with the manufacturers for subsidized rates, because we're going to look into pulling a lot of these in terms of forecasting, in terms of supply chain. We'll have to be able to pull, not just for the ones placed from NTB, but other private sector who we may identify was able to place one or two of these molecular equipment within themselves, because it's now very affordable. I know some private sector would also want to buy. Of course, we've started hearing some people who want to even get one platform for themselves because of the kind of patients they come. So consolidating that and ensuring that it helps us to subsidize what comes into the country. Then we would also use the Global Fund Grant GC8 to strengthen the system in terms of forecasting, the last mile distribution. If we're able to do it within what we have placed in the community, we are set for sustainability, because with dwindling funding, it means that we are already fixed into the system, because somehow within the government, some things happen from the federal government to the state government to the private facility. So strengthening these, filling those gaps is what this GC8 will help us to do. And if we are able to build a lot more capacity, in fact, what we are thinking is that we're not just building capacity of those who will be hands-on based on the machines we're expecting. We are also going to build a lot more capacity, have market master trainers within country who can be deployed anywhere to ensure that whenever we get a machine, of course, we're able to build more capacities to be hands-on. And we also think of the fact that we would have to increase a whole lot of demands. And with that demand, it means that we will be having discussion of in-country placement for either a local distributor or someone, or the manufacturer having their presence. As of now, the minister has finished that agreement with the manufacturers, and presently they are trying to establish a place in Lagos so that we can help to reduce turnaround time and also manufacture. The minister is talking about manufacturing within the country and see how it can feed into the African hub, by then further reducing the prices and ensuring that there's a lot of value we tap from the value chain. And because if you have all the machines and we build all the systems and build the capacity, whatever we do with the Global Fund to ensure that we improve journey to sustenance, if we are not able to ensure that there is uptime within this machine, we would also lead to market failure. So having presence in country, ensuring that the spare parts are manufactured in country, ensuring that there's low turnaround time around the KPI. It would also help us to maintain uptime and ensure that the increased demand we have created, that we are able to meet it up with supply. Then finally, I would just want to talk about within this GC8 grant, we also know that the near point of care might not be the last. There will be other technologies that will come up, maybe nearer point of care or even point of care. So it will also create an opportunity for us to see if there are things we can, just to join one of those in the pipeline that helps in validation of newer products. So the critical gap filling that the Global Fund GC8 will do for the country, now that we have seen it all, a whole lot that happened in the funding landscape, I think is a point for us to seriously think how to shape the market. With these 5 points I've presented, I know that it will form like a framework that can help us to put certain steps to ensure that this Global Fund grants coming in helps to set up the system, both lab system, diagnostic network to improve it, both the system of forecasting distribution to ensure that we can do last mile distribution to these PHCs or any of those facilities closer to the community to ensure that it's strengthened so that we can, as a country, still ride on that even when the funding is not there. So those are the points I have to put in. Thank you very much.
Thank you, Obioma. Thank you, Obioma and Arnab, both of you. Excellent points, and it really shows of the major shift that is happening, not just in the financial landscape, but also in the building of the systems at the country level, and how the GC8 is really positioned as as you call it, gap filling to strengthen those national systems that are able to then deliver the technologies, the newer technologies. So that I really appreciate both Arnab's points from a kind of market point of view, the diagnostic procurement facilities, and Obioma, your wealth of experience. I have hundreds of questions for you on the concrete examples but let's move for a minute to the point of private providers, because when we talk about those providers in the communities, those informal providers that you're talking about, or the models that you share around pharmacy engagement, I would love to call on our panel members that really do this on a day-to-day basis. So Dr. Shakaya and Prachi are both heavily embedded in having the private practitioners and the voice of informal providers as part of this world. So maybe Dr. Shakaya, if you are with us, I would love to hear from you, as a private clinician, from your perspective, if we see about how these GC8 proposals are filling gaps to strengthen systems at country levels, what value do you see, and what needs to be really done so that we get the formal reporting and referral system strengthened? Can you talk a little bit or give an example from Kenya about that? And then I would love to hear Prachi talk about her experience with tongue swabs in India. Dr. Shakaya, are you with us?
I am with you, Petra, but unfortunately I got rather difficult internet, so I'm not quite sure whether it will last my 5 or so minutes that I had thought I was going to talk to you about these issues.
We can hear you loud and clear, so please go ahead with us right now.
So yes, as a private practitioner, and I feel a little privileged because I tend to work in mostly what one would consider state-of-the-art private healthcare facilities. But really, at the core of the TB response are private providers that are close to the communities where TB occurs. And so in my country, the healthcare system has been divided into various levels, from level 1 to level 6. And private providers in level 2 and 3 are the most common. Very large numbers of private providers, and of course, there's always a challenge in how you engage so many of those providers. But our experience in Kenya is that if you do get a network of these providers engaged, then the numbers of people who get screened for TB and who get tested for TB and eventually get identified to have TB gets to become very large. And the beauty of the new tests that are coming in, and also newer technologies with digital X-rays and AI, is that we think that is going to enhance the quality of care that is provided by these providers. So for me, I see a great opportunity going forward in engaging a wider number of providers using digital technologies, using new technologies that can be brought down to the lowest possible level so people have better access to TB diagnostics, and therefore a real possibility of engaging a wide array of providers that can then enhance the TB response in our countries. I think that for me is key. Yes, I know the larger providers, the bigger facilities are important, and even at that level, quality of care is important. And I think newer technologies will also be needed at that level. But tuberculosis being what it is, mainly concentrated in people in the lower socioeconomic levels of the health of the social order, as it were. I think engaging smaller providers and providing those providers with tools that they can use easily would make a huge difference going forward. Yeah, so that's what I think should happen going forward. Thank you.
Excellent points. Thank you so much, Dr. Shakaya. Prachi, would you want to add on to that?
Yes, thank you so much. I just wanted to let everyone know that what my colleagues have said, it's very pertinent, and we in World Health Partners have been implementing the private sector programs from a very long time. And in one of the slides where Mohammed had presented, that we implemented PPIA from BMGF and then transitioned to JEET and then to the government taking it over. We have seen and we have been partners all along there. And what I feel is working with the private sector, we need to treat them as partners in care delivery rather than just simply sourcing, thinking them of just having reporting from just a minute, my dog is here and I just need to get her out. Sorry for this.
Okay. Prachi will be back, and I do see that also Dr. Azadar is here from Mercy Corps, and I would love to hear from Pakistan's perspective. And I did see Dr. Shah from the Philippines as well. So please, if there's anyone in the audience that wants to share their thoughts or their questions, please raise your hand, and Prachi, you can take over. But get questions in the chat or raise your hand, because we would love to hear from you about your experiences and your questions. Please go ahead, Prachi.
Yeah, so I just wanted to let you know that World Health Partners, we are actually been piloting very innovative approaches to improve the TB case detection by engaging with the informal healthcare providers. Not to say that we do not work with the qualified providers, but we have been focusing on working with the informal healthcare providers, who are often the first point of contact for patients in underserved communities. So, and in many parts of our country in India, there's a significant proportion of symptomatic individuals. Initially, they seek care from the informal providers, especially in the rural and hard-to-reach areas, rather than going to a very formal health facility or the government hospitals, wherever they are. So, and everyone knows that traditional TB diagnosis relies on the sputum samples, which can be very difficult for many patients to produce. And we have been seeing it in our program that a lot of this has created a lot of issues for us, especially the children, elderly individuals, and people with disease. Tongue swab actually is sampling offers a very simple, non-invasive alternative that can be collected easily, even in the community setting. And this we have been trying because we We have our own pathology lab, we have the gene expert, we have the TrueNat, and we've seen a lot of issues, and we've seen a lot of people are left out because either they cannot afford, it's very expensive, and until and unless the government steps in or the donors provide for the money, for a very common man, especially living in villages, it's very difficult and expensive also. Tongue swab is something which is very, very simple and non-expensive as well. So we've been trying it out because, first of all, tongue swabs are very painless and very easy to collect. They are particularly suitable for decentralized screenings and community level testing, including through these informal providers. So we've been implementing a research project in partnership with McGill University in Delhi itself, where we have engaged these informal providers, trained them into finding out TB presumptive cases, and then identifying and then sending them to labs and getting their diagnosis to see that what kind of patients they are identifying. And we've also engaged with these informal providers, these rural practitioners who also frequently see patients with respiratory symptoms. So the approach typically includes that we identify and map these informal providers in our project area. Then we train them on basic things like recognizing presumptive TB symptoms, collection of tongue swab samples from symptomatic patients at their clinic, and then transportation of samples to a molecular testing lab, which happens to be we have our lab here. And then later on notifying and linking them with diagnosed patients with the government TB treatment so that they get access to the treatment that is available in the government sector for free. The research is still in progress, and the further trainings will start in early next month. So the results are still not out, but we are very, very hopeful because we see a lot of advantages in this model. Of course, one is early detection, where the patients are tested at their first point of contact, where you see there's a lot of leakage that happens earlier. Then higher acceptability. Many patients prefer tongue swab sampling, which we assume because we've seen this in COVID that was happening. A lot of these tongue swabs were testing to COVID as well. And then one thing which is very, very unique of this is its operational simplicity. Sample collection will require very minimal training. And then, of course, we will be able to reach a lot of people because informal providers will help us access populations that routinely do not reach the public health services. So this is what, and I think I'll be very happy to share whatever evidence that we are able to generate through this research. But I think till now we've got very, very positive reviews on this. And hopefully once we start implementing it, after the tongue swab, then we are very sure that there'll be a great program impact where we will be able to see some increased TB case detection in the underserved population. And of course, the diagnostic delays will be reduced because a lot of times we are also struggling with gene expert cartridges not available or supply side issues, as it happens in any other country also. And plus, we've also seen there's a greater engagement of these private and informal sectors in TB elimination efforts. Of course, after a lot of effort and a lot of behavior change campaigns have been put into place. So I think this is something that we are very hopeful that is going to give us a lot of good evidence and data, and we'll be very happy to share as and when the research comes out. Thank you.
Thank you so much, Prachi. So that's excellent news. It can be done. It sounds like you are working on the tools and the training and the materials to actually show the evidence, and that is fantastic. Your call for digital integration, Dr. Shakaya, is very clear, and that does indeed allow us to go much wider than to the larger facilities. So that's we all need to be thinking about how to integrate that and how to make that part of any proposals. So I would like to now do a round where we call on each of our panelists. I mean, I still want to open up the floor and hear from any participants, anyone who is here. If you have questions, raise your hand, please, please. We want to hear from you, and put your questions in the chat. But in the meantime, I think just to keep us moving, I would love to hear from each of our panelists one specific nudge towards if countries are writing their funding proposals and want to include private sector engagement in their funding proposals in this current time of tightening fiscal and financial and political space. I know, Obioma, I will give you the floor first because you started off, you already mentioned the gap filling. But what is it that countries that are completely new and haven't really done a lot, as you already have within Nigeria, where would you start? What would be some of the key work that needs to be done? And I'm thinking about some of the mapping that you're doing and some of the, but please, from your point of view, what are key points to build into a funding request? And then I would love to ask Mohammed the same question after Obioma. And then we'll go through, if I don't see anyone, I see Dr. Azadar has put himself in the video, so I'm hoping that he's ready to speak or ask a question. Let's hear from Obioma and then Mohammed, and then Azadar, if you want to come in after that, would love to hear from you. Obioma, go ahead.
Yes, thank you very much for the question. So I'm also going to talk based on our experience because we also had some trial and error. So the first thing is comprehensively to map. For us, initially, we left private sector with faith-based organization and private for-profit. We didn't know the wealth within this informal sector that are closer to the community. So now, when we started the PSE, that's the private sector engagement with the Global Fund in 2019, one of the things we did was mapping comprehensively and bringing all those people on board. Now, there are key things with the regulatory bodies and frameworks that will say, oh, are they recognized? Are they not recognized? But it got to the point where we just had to say, where the TB patient goes, where the presumptive goes, is where we go as a program. So what we are looking for is a presumptive. So we had to be convince ourselves towards that for us to move into those informal sector and to see the number of presumptive that go there for things that they don't have index of suspicion towards is amazing. So that comprehensive mapping, then engagement. So engagement is where the classification is done because they are also limited. So what can the faith-based organization and private for-profit do? What can the informal sector do? So the workflow is built. In fact, in the private sector action plan, which is a very important document, which helps to practicalize what you have in the national strategic plan and shows you like how to do it, technically how to do it, who does what, how would they link, and mapping each of these people to the hub. There's a hub and spoke method where the informal sector, because they might just identify and refer, they may not be able to place on treatment. Where do we map them to? And not just to say, oh, when you send them to a public facility or send them to a private facility. You need to map them and say, you are reporting to this facility. This is where you send in patients to. So identifying, mapping, and also helping in terms of linkage is one of the key things that a country will need to do. Then in engagement, there are different levels of engagement, but we've come from experience. We've known that public sector find it very difficult to engage private sector. So you may need an intermediary organization. Like Mohammed said, he said we have a PR IHVN, which plays a role as intermediary organization for us. And within different states, we also have different organizations which they kind of oversee. These intermediary organizations are able to ensure that they map, they link them to us, speaking the language they know, because we come with all the policies and regulations and all that. We may not be as practical as these private sectors. So they will need to also hear from another private sector who knows us, who knows what the guideline is, who can help us to interpret to them and also help us in building their capacity. Then you will not go far away from incentive. And I feel for even the next grant is one of the things that will be key, because you can work towards sustainability. How exactly am I going to ensure that I keep reducing the amount of funds used for incentive by finding a way of putting in sustainability into what we do. So if we're able to set up a system for last mile distribution to these communities, we can now ride on what the government has and say, okay, let's ride on what government has. Now we have practicalized it. We can use this way to embed it into what government does in terms of distribution. So that gradual approach of also ensuring that you integrate sustainability into it is very important. And you just have to have your target. What are you working towards? Have a baseline, have a target. The target might not be so ambitious because you're starting. The first few years you're going in is more like you're doing a lot of groundwork. And you see, for us, we went from 14%, 20%, 23% contribution. You also have to be realistic in that target, because you will know such that you don't judge yourself wrongly. The first 2 years you might be doing massive engagement, massive capacity building, and you're expecting that same time to jump and have maybe 30% contribution. It might not be, but you now weigh yourself based on the processes. Have I been able to engage 90% of the people I'm supposed to engage? Have I been able to engage this before you turn out into the target in terms of how much contribution am I getting? So with all this and ensuring, I think one of the things that are important is that private sector is capital driven. So you have to be a lot more conscious to ensure that whatever you do now, how do I transit? How do I integrate? How will I get it off so that we will use less the next time to also deploy this? Thank you very much.
Thank you, Obioma. Really clear points. Mohammed?
Yeah, thank you very much. I just want to highlight that from Global Fund side, private sector engagement is considered as one of the cost-effective investments. So because the return from that investment is really huge. So I just want to confirm and also to encourage everyone that as part of prioritization, we shouldn't deprioritize private sector engagement. And we already have extensive experience in implementing different innovative approach, depending on the country context, to engage different private providers, including at the lowest level and up to the tertiary hospitals. And these are already contributing a lot, and that's where most of the people with TB symptoms go. So the investment should also proportionally directed to that. That for us is part of efficiency and optimization. And innovation, Global Fund encourage countries and others work with all those who are funding innovative, including research and development and early adoption of those innovations. And I just want to highlight that the Global Fund already supporting 13 countries to implement NPOC in 2026. We have already started last year. They are already going to receive all the tools, the machines, and the commodities soon. And some of those, including Nigeria, Kenya, South Africa, and Philippines, Indonesia, are part of those 13 early adopters. And we have been working with other partners. We receive additional funding to support, to co-finance some of those procurement and accelerate implementation and learn more, especially on the operational side. Now there is no question. WHO already reviewed all the data, evidence is there, and I don't think we need to continue using microscopy from now on, because you have alternative even at the community level, at outreach and for private sector. So Global Fund is working as part of market shaping as well, volume-based market shaping, and contributing to all discussion on the price of the machines and the commodities, including the training component this year already being implemented. And some of you are part of this early adopters implementation. We hope to generate some evidence which could help and boost the confidence of other countries to incorporate this in the GC8. If we don't incorporate in the GC8 funding request, then you'll miss opportunity unless we find money from somewhere else, including domestic fund. So I'm just encouraging you, while you are working on the GC8, incorporate the new innovations, all the tools, including ThankSwap, pooling as well, and NPOC, and all the new innovations as part of your funding request, because Global Fund is already advocating to do this. Because we don't have enough money, we need to optimize our interventions and save the funding so that we can cover more people with the little money we have. We are not expecting massive reduction from allocation. You'll hear that. But whatever money available, even from domestic funding, should be used efficiently. And I think there are opportunities to do that. And private sector will remain as a priority to accelerate ending TB. Global Fund is flexible and available to accommodate any of the change innovations in the pipeline as well coming. Just be brave enough and then challenge our country teams to incorporate innovation. From our side, we are supportive of introduction of those innovations anytime, not just wait for the next cycle, anytime during implementation. And we look forward to that. The question will be if countries exclude those innovations in their funding requests in GC8, with all this discussion, that is when our technical review panel will come with questions. Why not? Rather than actually asking you, why are you incorporating NPOC or private sector engagement models in your funding requests? So we all are looking forward to work with all of you to make sure that the Global Fund investment catalyze overall additional investment, also to help you to accelerate toward this transitioning to new innovative and new tools. Thank you very much. Over.
Thank you so much, Mohammed. Well, we are at the full hour. We promised that we would keep it for an hour. I really want to thank everyone for your engagement in wonderful, excellent points in the panel. Thank you for your great presentation, Mohammed. We are in a new era. Financial constraints, political shifts are happening, but we have great tools. Now we need to make sure that we roll them out in the countries. Please, everyone who has questions, get back to us, get back to the fantastic panel members, anyone that has experience. There are great people that are working already with private providers and private sector at country level. There's lots of excellent examples. Reach out, build this in your GC8 proposals. This is where we can make efficiencies. And this is also the community that is the closest to where people seek care. And so we need to build those new bridges to make sure that people that are currently falling between the cracks and are not getting the TB treatment or the TB test that they need, that they are actually being served. And this is an excellent opportunity with the new point of care test and sputum pooling to help us reach those last miles. So with that, I would like to close today's discussion. I will thank everyone with a big, huge, happy weekend. Hearts to all the work that you do. Fantastic engagement. We are really happy that we were able to bring you all together today to talk about this important topic. Looking forward to hearing from you on how your proposals are developing and what your country is taking forward. And we want to see those examples of engagement of private providers, informal providers, faith-based organizations, medical associations, all those groups that can really reach out to those people that need it most. Thanks, everyone. Happy weekend. Till soon. Thanks so much.
Bye-bye.
Bye-bye, everyone.